Good afternoon, and welcome to our third session in our first virtual Successful Aging Expo 2020. Today's session is entitled Knee on Track Technology. My name is Al Manzi. I'm the president and CEO for Prairie Mountain Media and publisher of the Times Call. Before we start today, I'd like to remind everyone to visit our sponsors and the Expo, and you can do that through our website at the Times Call. And after today's presentation, there'll be a 15-minute or thereabouts question and answer period. Now, we like to take your questions first. Now, you can do them through chat or through the Q&A box at the bottom. You can type them in during the presentation so that we have them as soon as Dr. Hollaman is finished. Today's presenter, as I said, is Dr. Ian Hollaman. He's owner of Redtail Health. So please join me in welcoming Dr. Ian Hollaman.
Thank you for having me, guys. And we are going to just jump right in it. I am a doctor of chiropractic here in the city of Boulder, and I've been practicing for 12 years now. So I'm going to go ahead and get into my presentation. Here we go. So like I said, I'm a doctor of chiropractic, graduated and been in clinical practice since 2008. I have gone and kind of done some other fun things beyond that, Master of Science, Human Nutrition, and Functional Medicine. So we, of course, will always look at the inflammatory, right? Inflammation is a big name in the game, and but we do look to that inflammatory component to this. One of the things that we'll be touching on today is arthritis, and arthritis is most likely the most common mobility limiting issue in our society right now. And so through something called functional medicine, many times we get into other aspects that can influence that. So we see a lot of knees in this practice. Love knees because they are our ability to get from point A to point B. And we get to talk about a wonderful technology called knee on track, and that actually is knee decompression. There is no other system out there that I'm aware of besides this. This thing can deliver up to 28 pounds of pressure on a knee, which is a lot because we start off at 12 pounds and work up to there, and we have a 90% success rate with improving range of motion and decreasing pain with just one session. Does one session fix it? No, of course not, right? If that would be wonderful. But the same thing is that goes for medication and everything else. So we're going to get into that. Back here. So anyone here, are your knees not working? Well, if you're paying attention, there's a good chance that we've got problems. Knees have problems for many reasons. And what we have to understand is that the knee is more or less kind of a locking and unlocking mechanism, right? We've got our femur, we've got our patella, right? That little triangle bone. And then we've also got our tibia and fibula. And then in the middle of that knee, we've got that cushioning pad called the meniscus. Many of you are probably suffering from meniscus-related problems. And then there's ligaments, inside, outside, and then something called the ACL and PCL. And that kind of just helps us orient ourselves to the knee joint. Now, most common type of knee pain is usually not actually arthritic. The most common kind of knee pain is usually related to just use and wear and tear. Now, over longer periods of time, that will actually develop into arthritis, and that will develop into pain patterns. And of course, that can lead into that scary situation where we get in front of a doctor and they say, you're bone on bone. By the way, quick tip, most people are not bone on bone. So with that being said, we'll talk more about that as we go. But really, I want to focus and highlight the technology that we have here in the office. So I'm going to do a quick video that's going to talk about the knee on track device. This is a really quick video, just a nice little infographic, just to kind of show you folks out there, what does this tool do? Now, again, we're going to do a demo today, so you'll actually see it in action and what it does, and we're going to have an offer at the end of our presentation, so you want to stick around for what that special offer is for new patients, right? and coming in, having an evaluation assessment and really a trial session for the knee on track. So let's go ahead and roll this.
The Knee on Track system is a non-invasive therapy that offers a revolutionary solution for those that suffer chronic knee pain. The Knee on Track isolates the knee and offers safe and effective mechanical traction to decrease pain, rehydrate tissues, increase range of motion, and speed up the healing process.
All right. So what basically just happened right there was we created something called a vacuum. And a vacuum, of course, is that lovely device that we all cherish in our house that comes out once in a while and makes a loud sound. But really, the vacuum that I'm talking about here is the ability to take fluid from outside of a space, meaning outside of the joint, and bring it inside the joint. And what that means is more fluid means more space. More space means better movement. And better movement neurologically decreases pain. Basically, you have two receptors in your knee joint. One is called a mechanoreceptor, okay? And in a knee joint, as you'll see here, this is our knee joint, okay? There are actual little guys in here that will sense the movement of that knee, and they're called mechanoreceptors. There are also these receptors called nociceptors or nociception. And what they do is they tell us, ouch, it hurts. Knock it off. Don't do that, okay? Or you know what? That last run down the hill or that last run up the hill or that last ski run, not a good idea because I'm starting to feel pain. And so what's going to happen here, interestingly, neurologically, is when mechanoreception decreases, nociception, pain firing, increases. So as we advance through something called degeneration or the loss of function of a joint, you have more pain because there's less movement. Motion is lotion. And so as you, okay, normal knee joint, right? It can bend 90 degrees. We're doing great. And then as it starts to get that limitation, right? As you're having struggles with those knee bends and its problems going up and down stairs and quality of life issues are starting to come up because of mobility. It's really your brain is shutting down the ability for that mobility to happen because it's smart. We have innate wisdom. We actually have intelligence. And that means we don't want to hurt ourselves more. But when we actually increase the firing of the mechanoreception, which is what this knee on track is doing, it allows us to actually have less pain and more function, and that's a beautiful thing. So let's keep going, let's talk. So right now, what is the state of affairs as far as how we're actually dealing with typically with joint mobility loss, with pain, with chronic pain, especially osteoarthritis? Well, number one thing out there would be, of course, painkillers. Painkillers, things like Vicodin, hydrocodone, and of course, with wonderful side effects, including habit-forming seizures, constipation, weak breathing. Don't worry, the constipation will be covered by another medication, right? Unconsciousness, everyone loves that one. Unusual fatigue, bruising, and decreased sex drive. Okay, that may not be a problem for some people, but let's be real. Not great, obviously. The concern here is we know that there is an epidemic of hydrocodone abuse and associated problems with that, including fatalities, and it really doesn't address the root cause of why we have pain in the first place. Again, to say this, I'll say this again, but motion is lotion. And if we can increase mobility, even if you've been told bone on bone, I tell you what, I've seen some pretty amazing things by just getting that mobility improved and actually having the ability to avoid the surgery or cut down or decrease or eliminate the medication, right? So there are alternatives, of course, from those painkillers. Surgery. Now, this is a little bit graphic. I apologize here. There is something called a total knee replacement. It obviously is very common. Happens, thousands and thousands and thousands of these happen all over the country every day. The number one reason why people get these, again, is pain. And generally take about 3 to 6 months of rehabilitation. Half of total knee replacements, according to an American Orthopedic Journal, will require some form of revision, meaning typically another surgery. That means 1 in 2, which is not a great statistic. Typical cost of a knee surgery is $55,000. Now, again, some people will say, well, Medicare is going to cover this. Well, they will cover, yes, maybe the procedure, but they may not cover everything beyond that. There are co-pays that still have to be paid. There is rehabilitation time. There is pain and suffering. There is annoying your uncle to come take you to and forth from the hospital. There are costs associated outside of the surgery itself, right? And so that's a gross picture, so we're just going to move on to the next one. Cortisone injections obviously are another common medical approach, and it is very powerful. It's an anti-inflammatory drug, and it also is going to help reduce swelling. So for people, they love it. Now, the American Orthopedic Society has basically said you cannot do unlimited injections. Typically 2 to 3 per joint per lifetime is now the recommendation. I know people out there going, wait a second, I've had 5, 6, 10 cortisone injections. The more cortisone injections you've had, the more likely you are to have knee replacement or joint replacement surgery. Same thing goes with the most common knee medical procedure out there, arthroscopy. So arthroscopic procedures, which go in there, and you know, the idea is to maybe clean up the meniscus, this pad right here, remove some of the debris. In theory, a great practice, and it definitely has helped people. Unfortunately, many times what's going to happen is they remove maybe a little too much of that meniscus. Maybe they get a little more aggressive than we needed them to. And so the statistics are, once you have that arthroscopic knee issue or knee surgery, your chances of joint replacement, they really go up significantly. Okay, so again, cortisone, right? And we also have these things called non-steroidal anti-inflammatory drugs, NSAIDs. Things like ibuprofen, Advil, Aleve, etc. Okay, Tylenol is even in there. So what has happened is this was in 2015, right? So 5 years ago, pre-COVID, right? Everything's going to be PC now. We had an FDA warning come out. Assistant Professor of Medicine, Dr. Gregory Kerfman, came out with a report and basically said, hey, Harvard is saying through our research that the more often and the higher the dose of taking these non-steroidal anti-inflammatory drugs will be a subsequent increase in heart attacks and stroke. Not a great outcome. And so if anyone's ever gone through a heart attack, seen family members go through heart attacks or strokes, you know how debilitating that is. And quite frankly, I would just take the knee pain over that. With that being said, what else are we going to do? Well, we're going to do demo time, and we're going to actually show everyone here what this knee on track device is, what it does, why it does it, all that fun stuff. And then we'll have a little bit more, a couple more slides beyond that, and then we'll get to do some question and answer. Of course, this is only one of the therapy tools that we use in the office. This technology has been around for about 3 years. And the company who, I'm trying to remember the company who actually made this device is ErgoFlex Technologies, I believe is who actually put this device out. We do have cold laser. We have something called shockwave therapy for scar tissue breakup. There is regenerative medicine that we do in the office, including PRP and human allograft injections containing stem cells. These are all different options that we have on the table to help someone. What's most important to me is, can I help you? And why that's important is because we don't want to waste people's time and money. That's just quite frankly not okay with me. So when I have someone into the office for their initial evaluation, we get to have a talk about what's going on, an exam, and then I tell everyone, if you see improvements based on what we do today, I know I can help you. If you don't see any improvements today based on what we do, I know I can't help you. It's pretty straightforward at that point, right? So I'm going to go ahead and we are going to stop our share so I can get into our full screen. Great. And we're gonna move through the office here at Redtail. Aha, we have our willing subject right here. And we're gonna put our willing subject through the rigmarole, so to speak. This is Mark. Hey, Mark.
Hi.
How are we doing today?
Great.
Good. So what we're gonna do is we're gonna have Mark do a demonstration, just basically of a knee bend. This is what we'll always do with every single patient who comes into the practice. A knee bend, what does that feel like on a 1 to 10? Okay, great. Where's your range of motion restricted? Let's go ahead and do a trial on that device. Come back up. Let's do a knee bend, back and forth, right? Rate that pain again. And do you see any actually improved range of motion? Like I said before, 90% of the time, we will see a significant improvement in either range of motion or pain. It's either one of those. If I see a difference in one of those, then I know that there's a good chance we can help you, okay? So let's go ahead and we're gonna actually come from the side here so we can actually see Mark. And we're gonna have Mark go ahead and just facing forward, just go ahead and do a knee bend for me. See how that feels. Ooh. Oh, there's a little bit of a sound in there. We call that, well, we call that AGE, but what we also call that is there is a stage of knee osteoarthritis for that. That's actually called stage 3. So what we're gonna do is we're gonna actually put Mark in our device. He's already going for it. We're gonna kind of isolate upper leg. And then basically what I have is a bladder right here that we're gonna inflate so it kind of grabs the leg nicely, right? Ticklish?
No, not there.
And then I'm gonna go ahead and put that right here. And we're gonna pump this guy up. So we're gonna pump it up till it's comfortable. And usually 8 to 10 pumps. 7, 8, is that pretty tight right now? Okay. And then if we need to adjust it, just let me know. And then what I have here is a dial that tells me how much poundage we have. Always want to check how much pounds you're using first. So, and when things beep, you know they're important, right? All right, let's go here. Protocol, no. Set point. See, it was on 27 pounds. We're not going to do that to Mark today. We're going to drop you down here, Mark. And what have you been doing before? You know what your setting was pre?
I don't know.
Okay, so I'm going to do 18. You should be fine with that. So again, what's happening here is this whole unit is now moving that way, right? So what's creating is a separation of the knee joint. You doing okay? Okay. And what's going to happen is, like I said, there's a vacuum created, and that's bringing fluid into the joint, increasing the space of the joint, allowing more movement, right? More mechanoreception, which means decrease nociception. That's less pain. That's what we care about. That's why you come into me and you go, Dr. Ian, make it stop.
Please.
And please, hopefully with a please. So this is a 6-minute protocol. And then what we're going to do is we're going to go ahead and we're going to repeat. So what I want to talk with you guys about while we're doing this and while we're actually having this is we're going to move our vibration plate. And I wanted to talk about what are the stages of osteoarthritis, okay? So there's 4 basically. And that's a terrible marker. Let's go with purple. 1, right? Which is kind of our mild. That's a terrible marker. There we go. Mild. Okay, and you may not experience any pain whatsoever with that first stage. It's very common. You may not notice anything, okay? But there are changes developing. Even when we're invincible and we're in our teens and we're in our 20s, you're still starting to see changes actually occur in the knee joint. Now, the second part, okay, which is more of moderate, okay? What we're going to find with that is where we actually will start to experience some pain. That's probably the most common symptom. And so when we do feel pain, and this is pain that is actually not just once, not just after an injury, this is pain on a daily basis, okay? It's not high levels of pain, it's just moderate levels of pain. Usually If you're talking about a 1 to 10 scale, a 5 or less is kind of usually what we're talking about. As well, what we're going to also start to see with this is we'll see bone spurs, right? So we'll actually start to see some physical changes develop on x-rays. And then stage 3, what is going to actually start to happen is we're going to see decreased joint space. So the joint space is going to decrease, okay? Pain levels go up, and you may actually start to, you feel okay? And you may actually start to notice that you're feeling some swelling in that knee joint, okay? Stage 3 is also where we'll get something called crepitus. That's what you had just experienced, that crack, that cracking, right? That kind of joint cracking that's happening, that is called crepitus, all right? So C-R-E-P, crepitus. Good. And so 4 is where we start to see severe lack of motion, severe levels of pain, joint spurs. At the very end stages of stage 4 is where we will see bone on bone. Now, again, I just want to be real with everyone here. I have, in my career of 12 years, I have seen one case of true bone on bone. It is not common. It is usually more something that is being used as a motivational tool. So when you feel that, or you have people say that, get a second opinion. It does not hurt to get a second opinion, right? How are we feeling?
It feels really good, actually.
Yeah, so typically it's going to feel pretty good when you're getting it done. The other thing that we do in the office is a technique, a system that's called trigenics. And trigenics is a neurologic technique to actually strengthen the muscles. The muscles surrounding the joint are what move the joint. Remember, one of the key points of our presentation is the awareness that as we lose mobility, we increase pain. It's a natural neurologic mechanism, and it happens to everyone. It's just not fun. No one enjoys that. So again, instead of taking a pill, popping a pill, rubbing and hoping, trigenics, that's Trigenics, trigenics is a natural technique system to assess each individual muscle around the knee, right? We've got quad muscles, hamstring. There's a muscle on the back of the knee called the popliteus or popliteus, potato. And that muscle is what helps us to unlock and lock the knee joint. So fun fact, if you walk downstairs and you feel the knee pain then, that's usually your popliteus muscle. Oh, if you're getting more pain as you're going up the stairs, that's usually something called patellofemoral syndrome, chondromalacia patella, or patellar tendinitis. And that's usually more front of the knee problems. Okay, let's go ahead. He's cooked, so we'll stick a fork in him. And then we're gonna go ahead and come on back and let's go ahead and just do another little test. Hold on a sec here. Drum roll. And go ahead and let's do a knee bend.
Oh, that feels great. Wow.
Okay, so what was it prior?
I was not even parallel.
But pain level wise as well.
It was probably a 5.
A 5. Okay, what was it post?
No pain.
Okay. Oh, all right. Well, then we'll take a 0. I'll take a 0 any day. Thank you, Mark. Appreciate it. So let's go ahead and wrap up with a couple slides, and then I want to go ahead and take some questions from everyone. All right. Hope everybody's doing good still. This is exciting for me. I love being able to talk about this fun stuff because a lot of the stuff that we do really actually works. Back to here. So let's talk. Let's do just a couple testimonials, and you saw Mark do that. But these are some other patients here that have experienced this.
All right. So, like I said, the first thing is kind of how you were when we first started. And
it is the middle of July now, and I noticed after the first of the year, I was having lots of knee pain in an area I'd never had pain, right in here. And I also realized that standing up and sitting down were very, very difficult. I would have to be sure I was sitting in a chair that had arms, and I would gradually, oh, that was that. But I'd have to do the same thing sitting down. It was just in incremental stages trying to get down. Then I noticed the other knee started doing it too. And that's when in May, I lived with that until May, and then I realized I needed to get help.
Excellent. So then, what did we do? When we started after May, we started with this, and when did we start with this? First part of mid-June, right?
Yeah, this is my 5th week starting this. I came in 3 times a week, and I did my at-home therapy in addition. Right. And I noticed the second day a tremendous improvement. And this is me now, getting up and getting down.
That's wonderful.
Yes, it is wonderful.
Yeah, I know you were having troubles. You were having to push out of your chairs. So.
Well, it was the...
Oh, and I was going to go ahead and do the whole. This is another testimonial here, right here.
Okay. I was damaged in a skiing accident 18 years ago, and I've had surgery and I've had regular rehab, and nothing has given me relief until I've started this decompression, and it's giving me my quality of life back, and I'm able to walk correctly, and I'm able to exercise like I haven't been before, and I'm losing weight, and it's just been wonderful. I can recommend it for people that have bad knees. I'm also doing the back decompression that is helping me immensely too.
Now, he mentioned that right there at the end, that very, very commonly what we'll find is people's spines are heavily involved with their knee pain patterns. Also as well, obviously, when your knees stop working, you stop moving and you start gaining where you don't want to gain. So very commonly, people also need a little bit of assistance with some weight loss. And this is another fun thing that we do in the practice. Beyond that, though, your lumbar spine has a large branch of nerves that come off the back, and they split into different nerve bundles. Now, on the back of the knee, you've got basically a branch of those nerves, right, from the sacral nerve root, right, the sciatic nerve root, sacral nerve plexus, or the sciatic nerve root, and then a bundle of those is coming off of the lumbar nerve root, and that's basically L5S1, or 5th lumbar, 1st sacral. That then goes to the back of the knee, and it will hopefully turn on all the muscles that stabilize the knee on the back of the knee. Whereas on the front of the knee, the majority is usually L3, L4, and some L5. So what happens is, if you actually have a back problem, or better way to say that, if you have a knee problem, you really actually might have a back problem. And that's important to keep that in mind. And that needs to be evaluated. Part of a good exam is looking at the foot, the knee, the hip, and the spine, and looking at all of these factors rather than just focusing on the joint itself. Why don't we figure out why it happened rather than just, oh, it happened, and then here is your replacement or pill or procedure. This is one other testimonial here.
Hi, my name is Judy, and I've been coming to Red Tail for about a month now because I have arthritis in one of my knees, and it was beginning to hurt pretty much all the time when I walked, and so I signed up to have Dr. Sam work with me on the knee with their various kinds of exercises and movements, and it was now it's been let's see, about, I said 4 weeks, I think, that I've been working on it, and I think it's progressed quite a lot. I don't always have pain-free days, but there's been a lot of progress, and I feel the knee is much stronger, as well as the muscles in my legs.
Awesome. How bad was
So again, that's 2 sessions a week that we were doing with her. That's 8 total. And we were doing a couple other therapies beyond that. But we were talking about stage 4 degeneration and pretty significant. So of course, I want to take questions from our viewers. I think that's really important to do that. But before we do that, I do want to go ahead and just let everyone know what special we're doing here for the Healthy Aging Summit, and just everyone out there who's actually been nice enough to pay attention to little old me for 30 minutes here. So that is a $47 new patient exam, normally $125, which includes an orthopedic neurologic exam, a trial of this knee on track decompression, and then potentially as well a trial on something called Trigenics. And again, these are both therapies that we use in the office to see if what we do here will actually help you. And then of course I sit down, I review those findings, and I give my best recommendations as far as what do we need to do, what's the severity, what else is going on, and how can we assist you in your goals of getting you back to optimal health. And that could be anything from I am wanting to play with my grandkids more. I am wanting to stay on the ski slopes. I am wanting to just go up and down stairs without pain. Or I just see that my honey-do list is piling up. And I know that if I don't get my knees fixed, I'm going to get replaced with someone else that will get my honey-do list done. No, maybe that won't be the case for you, but you never know, right? No pressure. So do we have any questions currently right now? Anything that I can take?
Do you have to wait to work out in between each session?
No. Well, let me stop there for a second. Part of this is what's going on. Usually if there's a lot of swelling, severe limited range of motion, you may not actually it may not be beneficial for you to exercise in the first place, because you actually may be causing more harm than good. One of the things I actually also didn't mention about cortisone injections is by relieving all that pain with a cortisone injection, many people will go in and push themselves too hard and actually create more injury as a result of that. But typically, no. Actually, remember, what I want people to do is use that principle of motion as lotion. So in between sessions in general, you're fine to do what you want to do. I just tell people, don't push beyond what your normal is until we start seeing significant improvements enough to then push you harder.
Dr. Hollaman, can you explain or describe how the process of decompression speeds the healing process? Because I heard you mention that, and I thought it kind of was like, well, how does it actually speed the healing process?
So a couple of different ways. One is the actual synovial fluid, which is inside the knee joint, has certain kind of healing factors, growth hormones, things that are actually helping to regenerate the joint on a regular process. By actually getting an increase in that synovial fluid, by increasing the vacuum effect, or more or less the draw of that fluid into the joint, you're bringing more of those healing nutrients in there, thereby actually, again, allowing normal biomechanics of the knee, which allows it to move. Healthy movement of the joint is actually a really positive signal to the brain, the nervous system, and that actually then also continues to facilitate more healing. The cool thing is and I don't have research to quote this, but what it really I've seen is people consistently say the movement is improving from week to week to week to week, and it's just progressively getting better over time. That's not just because it's just stretching tissue. It's because of what actually is happening inside the joint as a result of the stretch of the tissue.
So do your patients ever have an opportunity to move away from it and stay well, or do they have to come back for repeated decompression?
Exactly. 2 scenarios. One, again, it depends on the severity of where someone's at. So example, if someone's in stage 4, there's probably a chance that they're going to need maintenance, meaning they come in once a month or twice a month and they have actually, kind of just a maintenance session on that. What we're going to usually do is between 1 or 2 sessions a week for however many weeks we think it's appropriate. with check-ins on how they're doing. And then again, there may be other therapies in office that we may want to use. We may need to break up scar tissue that's developed. You know, again, on the front of these knees, that patella right here, many times, and in fact, the most common knee pain pattern out there is patellar tendinitis. And that's usually knee pain, feeling on the bottom of the knee, maybe up and around the edges of the kneecap. That's typically patellar tendinitis. That's a tracking issue. Once you get the actual knee tracking up and down as it normally should, because the muscles are turned on as they should be, well, that your body has its own natural ability to maintain itself. So that's the cool thing, is that the body can heal itself, the body can maintain itself. It also just depends on how hard you use your body. Boulder is Boulder, Longmont is Longmont. Everyone has their own kind of limits of how hard they push themselves or want to push themselves. And sometimes we push ourselves a little bit beyond what we do or should do, and then sometimes that requires some extra maintenance.
Are there any knees that wouldn't be a candidate for this? Like, what if somebody didn't have an ACL?
Yes. So if it's chronic, no, that is not actually a contraindication. If you acutely tore your ACL, absolutely 100% we would not do that. That's a surgical referral. That's not going to be fixed by what we have in the office. Now, that being said, if you have a total knee replacement, this is not for you. We are not going to do that. It is actually on our form that you'll see, which is an informed consent. If you have a TKR, total knee replacement, you are not a candidate for the knee decompression device. The other thing, it's obvious, but I should say it because it's true. If there is a suspicion of infection in the knee joint, or if there are signs of a knee infection, of course, we're not going to touch it with this device.
And you had touched your vibrating plate. Do you use that in combination with your knee procedures?
Sure. Yeah, absolutely.
And what are the benefits of the vibrating plates?
Knee vibration, basically, it's actually more or less a brain therapy. We're trying to actually wake up the brain to be able to actually improve that mobility, because what's regulating, of course, our ability to actually move is the brain. And so by working on an area called the cerebellum, that's eye movements, accuracy, balance, and coordination, we're actually also helping to improve muscular function. We have a lot of other tools in the office, pulse magnetic frequency or pulse magnetic field therapy, cold laser. I mentioned something called shockwave. If it's appropriate, we do have a nurse practitioner on staff, and we will do PRP, or human allograft injections containing stem cells. And those are both regenerative medicine therapies.
And speaking of those regenerative techniques, are they working longer term for the knee?
Well, currently, as it relates to the human allograft injection containing stem cells, it's on average 3 to 7 years as far as what we see with improvements and sustaining improvements. Partly that's because that's only as far as the research goes. I've actually done my shoulder. I've done my back. I did my shoulder 3 years ago. Absolutely no problems with it whatsoever. I'm very active. We have an 80% success rate with knees with regenerative medicine. So that actually is the #1 joint that responds to regenerative medicine. Everything else, it kind of depends on the scenario and the situation, but it's pretty phenomenal to see people from month to month. And it takes, about 3 to 6 months to see full healing or a plateau, so to speak, of what maximum medical improvement will be when you do something like that. It's also more expensive, right? So there's going to be a bigger investment with something like that. But we have consistently seen people not having to actually move forward with their knee replacement surgeries as a result of doing the human allograft injections containing stem cells. So pretty exciting.
Speaking of expense, are any of the costs associated with any of the procedures covered by Medicare or by any other healthcare programs?
Great question. I can speak to Medicare guidelines. Medicare guidelines currently don't approve, traction as it relates for the knee. We do keep the cost of those actually fairly low, which is kind of nice. So it actually turns really into a copay anyways, instead of having to, pay the copay. And actually sometimes the copays are more expensive than what we actually even offer in the office. So there are some certain things we do in the office that is potentially reimbursable. What we do tell people is we provide a courtesy service. We will generate a health insurance claim form. You can then submit that to your insurance for reimbursement. We do the best we can for that, but we don't make any claims that you will actually 100% receive reimbursement.
But it is qualified for HSA payments out of HSA plans, correct?
FSA, HSA, those are qualified. And of course,
Excellent.
if we start talking about things like regenerative medicine, we also do have care credit. It's a financing option. And I know people don't like to use it, but honestly, I've had people use it and have, the ability to now improve whatever it was, their golf game. They could go do things pain-free. They could sleep at night. There's really huge implications of having mobility in your life.
And what about some of the things, some of the newer things? 2 days ago, we had a session on CBD and medical marijuana use for pain. Are you seeing that in your practice where people are using these effectively in combination with some of the things you're working on?
Yeah, and I would say so. In general, I don't tend to carry them. I mean, we carry over 100 different products in the office, but it's kind of like everyone has a fish oil and everyone has a CBD or a THC product. CBD, right, is of course non-psychoactive, and it is going to be where more of the anti-inflammatory benefits are. So I'm always going to push people that way. Whereas THC is going to potentially start to get into more side effect issues and kind of cost benefit analysis. One of the downsides of CBD, and I would say, and also THC, is just cost. Long-term cost-wise, it is going to go at some of the inflammatory component, but personally, this is just me personally, I would rather address biomechanics and then address weight issues, and I would address internal inflammation as well, and that could be through essential fatty acids, making sure that they have, let's say, collagen. There's a lot of things you can do nutritionally to actually help the joint, more than just obviously MSM or chondroitin or glucosamine sulfates or things like that. So yeah, I think it should be in the bag of tools, but I don't use it as a primary therapy.
And so could you spend a little bit of time on anti-inflammatory foods and also supplements that you would recommend somebody who is in their 60s that's dealing with degenerative knee issues and is trying to prolong the movement that they do have?
Yeah, absolutely. I'm actually thrilled that you asked that question. So almost all the clients I see have some component of inflammation as part of their pain pattern. Okay. Because as inflammation builds up, remember, it's going to fire that nociception, which is going to increase pain. And then it can actually generate inflammation in the form of swelling, which is going to decrease mobility, right? And cause problems. So the number one cause for osteoarthritis is actually impaired blood sugar handling. Meaning, as you start to see increased levels of blood sugar, your A1C is elevated, your blood glucose is elevated, or those may not be elevated, but your insulin is elevated, like insulin resistance is what it's called. And they're all kind of moving you towards prediabetes, diabetes. As that starts to happen, that creates chemicals that float through your body, and those chemicals deposit onto tissues. And what happens is that creates an immune system reaction. Your immune system is brought into those tissues. Damage actually occurs as a result of that because you can't essentially regenerate as fast as you're degenerating. And then you start to have, again, mobility and pain issues as a result of it. It actually literally will cause you to lose cartilage as you have more and more blood sugar handling problems. So that's going to be the most common issue. There are, of course, other examples like rheumatoid arthritis, an autoimmune disease, right? A very severe issue. Your immune system is making its own antibodies and it's attacking your own tissue. There are other inflammatory-based conditions that we deal with in the office and try to work through. But that does require actually supplementation, dietary changes, and sometimes, lifestyle recommendations. In general, if I'm going to actually say, look, I'm generalizing now, we're going to usually recommend a paleo-Mediterranean diet, which means lots of lean greafies, right? Or not lean greafies, lean protein, green leafies. Okay. It's lunchtime, obviously. And fruit, nuts and seeds, healthy fats, olive oil, coconut oils. We're going to recommend certain things to actually promote the body's ability to heal itself and remove inflammation. So as we get into more of that standard American diet, of course, you're going to start to build up more inflammation. And that is a big part of it as far as what people are suffering from.
Well, that was wonderful. As usual, I've heard you present before, and I think you do a marvelous job. And want to thank you. You answered so many questions, and you've given a lot of people. I mean, knee pain and back pain are the two things that almost everybody deals with, and so trying to learn as much as we all can about that, and having you present to us was enormously beneficial to everyone that was able to view this today. So I want to thank you so much, and I wish you well, and hope to see you again soon.
Yep, great. And then just one more time, you guys give us a call. I think the offer is good through the end of this week. And that is, again, literally $47 for that new patient exam, trial session, and then a sit down with me, and we'll go through your options.
Awesome. Thank you again. Thank you, ladies and gentlemen, for joining us today. We'll see you same time tomorrow, same channel. Take care.